Hello everyone, I'm Dr. Karthika Nambiar from the Department of Orthodontics. My topic for presentation today is going to be understanding Class II Malocclusion, mainly focusing on the treatment modalities of Class II Malocclusion. So I will be giving you a brief introduction on what is Class II Malocclusion, its etiology, clinical features and classifications, and the main focus being the treatment modalities. So without further ado, let's jump right into the topic. So before discussing what Class II Malocclusion is, let us brush up our basics on what a malocclusion is. So the definition of malocclusion is a condition where there is a deflection from normal relation of teeth to the other teeth in the same arch or the opposing arch. This definition was given by White and Gardner. There are different malocclusions, there are different classifications for malocclusions given by different authors, but our focus today is going to be Class II Malocclusion. So now what is Class II Malocclusion? Class II Malocclusion is nothing but where the mandibular arch is in a distal relation as compared to the maxillary arch. So in other words, we can say that the mandible decides to chill far back as compared to the maxilla. We have two images here. So the first image shows a normal occlusion or a Class I occlusion where the mesiobuccal cusp of the maxillary first molar occludes with the buccal groove of the mandibular first molar. Also, the maxillary canine lies in the embrasure area between the mandibular canine and the mandibular first premolar. This is an ideal occlusion. However, in the next image we can see that the maxillary distobuccal cusp of the maxillary first molar, it occludes with the buccal groove of the mandibular first molar, and also the maxillary canine is far ahead as compared to the mandibular canine. So this gives the mandible a distal relation as compared to the maxillary arch. So this is Class II Malocclusion. So now Class II Malocclusion can be classified mainly into dental and skeletal malocclusion. So when do we say a Class II is skeletal in nature? When there is either a prognatic maxilla or a maxillary excess, a retrognatic mandible, or a combination of both maxillary prognatism or mandibular retrognatism. When we say that the malocclusion is dental, it is classified as Class II Division 1, where the maxillary anteriors are proclined. The molars are in Class II relation, but the maxillary anteriors are proclined. Division 2, where again the molars are in Class II relation. The maxillary incisors are retroclined and the lateral incisors or canines are proclined as compared to the central incisors. And a subdivision where there is a Class I molar relation on one side and a Class II molar relation on the other side. So now we have discussed what Class II malocclusion is and how it can be classified a Class II malocclusion. So every problem has a reason and every reason has its own solution. So we know what the problem is. Now let us talk about why does a Class II malocclusion happen. So one of the main etiological factors for Class II malocclusion is hereditary, where one of the parent might have a prognatic maxilla while the other might have a retrognatic mandible. So a combination of both of these can lead to a Class II malocclusion in the child. The other factors may involve congenital factors, where there can be a malformation in the first and second branchial arches or certain mutations in genes leading to different syndromes such as Pierre-Fauchard syndrome or Treacher-Collins syndrome, which has a significant characteristic feature of a retrognatic mandible. So this is also a feature of Class II malocclusion. Other factors include environmental factors. There are various environmental factors, natal factors, prenatal factors. So there is something called as an intrauterine molding, that is, it starts from the fetal posture. So during when the child is in the womb of the parent, sometimes the fetus places his hand on the lower jaw, thus leading to an intrauterine molding and leading to a Class II malocclusion in future. Natal factors can involve certain factors such as forceps delivery, where during forceps delivery, because of the forceps action, it can cause to an injury to the TMJ, thereby leading to TMJ ankylosis and again leading to a retrognatic or a small sized mandible. Various other factors such as habits play a very important role in Class II malocclusion. Habits such as thumb sucking or mouth breathing, where the different positions of the thumb in the intraoral cavity or the positions of the tongue can lead to a retrographic mandible or proclined incisors, both of which can cause class 2 features. So when a patient comes to you, how do you recognize whether this patient has a class 2 malocclusion or not? So we can identify this with certain extraoral and intraoral features characteristic to class 2 malocclusion. So extraoral features of class 2 malocclusion involve a convex profile, a deep mental-labial sulcus, the lips are incompetent, that is they do not touch each other, a lip trap and a short upper lip or a hypotonic upper lip. Intraoral features can include a class 2 molar relationship as explained earlier, proclined maxillary anteriors, an increase in the overjet, an increase in the overpipe, and a V-shaped dental arch. Division 2 features are different from Division 1 features, where in Division 1 where the anteriors are proclined, in Division 2 the maxillary incisors are retroclined with proclination of the lateral incisors or canine. Von der Linden has classified Division 2 also into further types based on the position of the lateral incisors and the canines. So the other features are that the patient may have a straight or a convex profile, there is severe deep bite, and the upper incisors, the lower facial height is reduced. So we know why the class 2 malocclusion occurs also now. Now why do we need to treat a class 2 malocclusion? So class 2 malocclusion can have various effects such as functional problems and aesthetic problems. So various functional problems such as chewing, speaking and breathing. Aesthetic concerns involve poor facial profile and self-esteem issues. So in a growing child, if the patient has a class 2 malocclusion with rabbit teeth or buck teeth and they go to school, they face a lot of bullying in their school or there is a lot of peer pressure. So this causes a trauma to the psychology of the child. So these are also one reason why we need to correct the class 2 at an early age. Also long-term increased risk of trauma to incisors. Because of the severe proclination of the maxillary anterior teeth and because of the severe deep bite, there is a lot of trauma to occlusion. So these are the basic reasons why we need to correct a class 2 malocclusion. So a question should arise that if a patient reports to you in the early mixed dentition and with a class 2 malocclusion, would you start treatment or would you defer? So first of all, in such a case, you would weigh the following factors, such as if there is a predisposition to trauma, as discussed earlier, psychological assessment, problem areas such as skeletal, dental in all three planes, anteroposterior plane, vertical plane or transverse dimension. So if these problems exist, the ideal cases for early intervention involve a patient with severe deficiency of mandible, severe proclination of maxillary anteriors, a severely narrow maxilla, or habits. Class 2 correction can be also as an intervention of habit correction. So there are various diagnostic aids as to how do we diagnose a class 2 malocclusion and whether the class 2 malocclusion is of skeletal nature or dental nature. So the first and foremost being history taking. In history, medical history and familial history are of utmost importance. Medical history will involve certain respiratory problems or adenoids which can be a cause of class 2 malocclusion. Familial history, as discussed, hereditary is one of the important factors why class 2 malocclusion occurs. So with this we will come to know what the etiology of class 2 malocclusion is and we can correct them accordingly. Extraoral and intraoral examination, we discussed the features, the clinical features. Identifying these features, we can decide whether what treatment modality is to be needed. Radiographs and study models. Radiographs, certain cephalometric radiographs, we have certain cephalometric analysis with which we can identify whether the class 2 is of skeletal or dental origin, whether the maxilla is at fault, whether the mandible is at fault, or whether it is purely dentoalveolar. Study models is a life-size replica of the oral caricature. So it is like we have the oral cavity in our mouth, we can correctly assess the amount of overjet, the amount of proclination, or any tooth size arch material discrepancy. Based on all of these factors, we can come across a proper treatment plan for a class 2 malocclusion. So now that we have diagnosed the patient for class 2 malocclusion, before we jump into the treatment modality, there is something called as an envelope of discrepancy. So envelope of discrepancy is the range of tooth movement that can be accomplished within the biological limits of the system. So this is an essential component of treatment planning, not only for appropriate position of the teeth, but also for restoring a stable occlusion. We cannot be all heroic and move the teeth right, left and center just to know that post-treatment there is no stability, there is severe relapse of the treatment. So we need to know how much can we move the teeth or the jaws for that matter. So the envelope of discrepancy mainly consists of three envelopes. The inner envelope consists of how much the tooth can be moved orthodontically alone. The middle envelope has orthodontic tooth movement as well as growth modification, and the outer envelope is purely surgical. So this is the image of the maxillary arch. As discussed, the inner circle, the pink circle, shows how much tooth can be moved with the help of orthodontics alone. The yellow one is with orthodontics and orthopedics or functional appliances, growth modification in general. Skeletal anchorage is another that has been recently added, skeletal anchorage involving tags. So this is how much tooth movement can be added with the help of tags. And the last one is surgical. There is another envelope that is recently added for distraction osteogenesis. That is more, if you require more range of tooth movement, we do something called as distraction osteogenesis. I will be discussing this in the future slides. Similarly, this is for mandible. How much range of tooth movement for mandible can be done based on the envelope of discrepancy. Now that we have discussed the problem, which is class 2 malocclusion, and the reason behind the problem, that is the etiological factors for class 2 malocclusion, this brings us to the end of the first lecture. Further down, we will be discussing about the treatment modalities, which is the main focus of the lecture, in our second part.